My dear friends, once again, myself is Prof.Dr.R.R.deshpande. We are in the Ayurveda College, Bigdi, Pradhikaran, Pune 44. Actually, today is a Tuesday, that is the 30th of August 2016, and today we are going to see, rather we are seeing the how to perform the examination of respiratory system. This particular shooting has been done in two parts. First part is the examination of upper respiratory tract, that is nose and oral cavity, etc. And then we have also seen how to perform the inspection of the chest. Now I am going to start how to perform the further test, that is palpation, percussion and auscultation. Let us move to the slides. We are going to see the respiratory system examination presented by Prof.Dr.R.R.deshpande, and my mobile number is 922681060. Okay. We are going to start, ready, with the palpation of chest. So here we are going to measure the dimensions with the help of cardboard and measuring tape. Then we are also going to check the expansion by measuring the circumference with the help of the tape, and that we are going to check at the nipple level. Then we are going to check the palpation of the chest examination by putting my particular hand, that is the palm and thumb, at near the nipple or the sternum. Then we are going to see the position of trachea by putting the hand over there. Then lastly, most important is tactile vocal fremitus, that is TVF. Palpation of the chest, first thing is a measurement of the chest with tape and cardboards. We are going to see the transverse and antero-posterior diameter. Then expansion is measured in form of circumference, that we are going to check at the nipple level. First we are going to ask at the resting condition, that is after expiration, and then after deep inspiration. Remember, your chest expansion is expected to be about around 5 cm after deep inspiration. That is, I think, the criteria for your appointment as particular services like military services. Then palpation of the chest, about respiratory movements and the chest expansion, that we are going to from front, then from the back, and also at the apices of the lungs. So here I am going to put my palm at the nipple level, and I am going to check how my thumbs are moving equally on both sides when the person is taking a deep inspiration. When I am asking him to turn back, then I am again putting my hand at the mid-scapular region, and again I am showing you how my thumbs are moving apart equally on both the sides. Then also at the apices. Lung apical part is very important because again tubercular infections are always taking place mostly at the apical region of the lung. Do you know any exception? Exception is HIV patients. In the HIV patient, tubercular lesion may not be found at the apical, but it may be at the lower zone. This is the difference in the normal tubercular patient and the tuberculosis with HIV infection. So this we are going to see as a demonstration. Then position of the trachea. In the previously we have just observed the head of the sternomastoid muscle, but here I am going to put my fingers in between that particular head, and then we are going to see whether the depth is equal or not. Tactile vocal fremitus, it has a physics principle that sound waves travel faster and louder in solid medium as compared to the fluid or the air medium. So here I have given the examples at the bottom. You can see that in the solid medium like fibrosis, the TVF is increased, and in air or liquid like pleurisy, TVF will decrease. Here we are going to see ask the patient to say 111 or 999 because these particular numbers are having nasal triangle, and I am putting my ulnar border and the right side, left side, below the axilla and on the scapular region. So TVF we are going to check. In consolidation, TVF always increases, and in pleurisy and pneumothorax, tactile vocal fremitus decreases. As I am not going to read all these lines because we are going to check all these things during the demonstration. Next will be the percussion. That I am going to do from the front, back and infra-axillary area. You know that everywhere there is air in the alveoli. So the sound will be resonant. But in the cardiac region, the sound will be dull. And that is called as cardiac dullness. That is the most important part. Auscultation is very, very important with the help of stethoscope from front, back and infra-axillary region. Intercostal spaces are auscultated. Air entry is checked, whether it is equally on both sides. Then we are going to see the type of the breathing, whether it is a vesicular or bronchial. Then we are going to see adventitious sounds. And lastly, we are going to check the vocal resonance, that is VC. So intensity of the sound is same, that is called as AEBE, air entry bilaterally equal. Then type of the breathing, we are going to check. Then air entry denotes you the intensity of the sound, and type of the breathing will be the quality that you explain with the vesicular word and the bronchial breathing. So this is the expression of vesicular and bronchial. It is like a rustling of leaves because of the distension and collapse of the alveoli. And bronchial breathing is heard on trachea because it is a blowing of air through pipe. Naturally, anywhere in the lung, if you get a bronchial sound, that is pathological. That is very common. Last is adventitious sounds. First type of the sound is whistling sound or the rhonchi, which are heard in the bronchial asthma and bronchitis. And bubbling sound or the crepitus, which is heard in pneumonia, pulmonary edema and CCF, congestive cardiac failure. Ayurveda, these words are sometimes translated as a Vataja Dhvani and Kafaja Dhvani. So first rhonchi are Vataja Dhvani and the second is a Kafaja Dhvani in Ayurveda. Vocal resonance, the principle is same like a tactile vocal fremitus. Sound waves are faster in solid medium and as compared to the fluid or air medium. Here also the patient or the person will say 111 or 999, and I am going to put the stethoscope on the chest. Remember, although these are all clinical, our examination, and we diagnose the patient as a provisional diagnosis, something like pneumonia, something like tuberculosis, something like bronchitis, but sometimes we may need some additional tests or investigations to confirm our provisional diagnosis. So these some type tests are X-ray test, which is very common, PA view, sputum examination for acid fast bacilli for tuberculosis, bronchoscopy and lung function tests like vital capacity, etc. by spirometry. So this will nearly the end of our session, but before that, this is only slide presentation. We are going to shift now to the actual demonstration of these all things. My dear friends, we will start actually the examination of the respiratory system, especially the chest, for palpation, percussion and auscultation. Now we are going to demonstrate few of the things. For example, first point I have mentioned as a measurement of the chest. That means in the inspection we just see that it is symmetrical, etc. But now here actually we are going to measure with the help of this type of some cardboards. Any type of cardboard you can take. So this particular distance, Dr. Kalyani, you can show them how we, if possible, how we can measure. This is called as a measurement of antero-posterior diameter. Is it clear? Now next. हात खाली ठेवा, काळे ठेवा. हे जवळ ठेवायचं म्हणजे मग ते आपला पण हात आहे. You can show them. हे जर distance घेतलं तुम्ही, this distance is called as a transverse diameter of the chest. So by this way you can decide whether the transverse diameter should be more than the antero-posterior diameter. Okay, thank you. So this is all about measurement of chest. Now actually we are going to measure the circumference by the tape. Okay. So this should be measured at the nipple level. So let me check out whether we can do it. Okay. So here is the nipple level and we are going to check the expansion of the chest. Okay. खोल श्वास घ्या. Here you can see nearly from 81 to 85. So normally it should be expanded for the 5 centimeter. That is called as a measurement in the form of expansion. Now, we are going to see the respiratory movements. For that matter, we are going to see from the front, back, and from the lateral side. Next. Now, for expansion, you have to keep this particular thumbs and palm like this. Okay? खोल श्वास घ्या, तिकडे बघा. घ्या खोल श्वास. See the movement of the thumb. सोडा. घ्या. Soda. Okay. So this is the expansion equally on both sides. That means air entry is equal on both the sides. Okay. पाठीमागच्या बाजूला वळा. You have to examine from the back side. For that matter, mid scapula. This is the scapula bone. You have to keep your thumbs like this and palm like this. खोल श्वास घ्या. सोडा. घ्या. सोडा. So you can see there is equal type of the movements. परत सरळ बसा. Now I am going to check at the apex region. For example, I have to keep the fingers like this. Okay? खोल श्वास घ्या. सोडा. घ्या. So both the hands are equally going up. So this is called as expansion at the apex region. Because many times, because of the tuberculosis, some part is fibrosed and that is not expanded properly, air entry is not there. So this is the expansion from anterior, from back, and from the upper side. Next. Now, position of the trachea, for example. Previously we have seen only the heads. Now I am putting my two fingers over here in the central part. That two fingers are having the equal depth. So I can understand the trachea is in the center. If it is not equal, some like this. So naturally it is inequality is showing. And because of the trachea is pulled or the pushed on the other side. So we have to check the depth by putting two fingers in between the sternomastoid muscle. Next we are going to see the tactile vocal fremitus. As I have already explained, the patient should say the one word like 111 or 999. So, and I am checking with this my ulnar border of the palm. You can put like now here only and say 11 or 999. 1. So upper part, middle part, and the lower part. Okay. बस. आता तुम्ही हात डोक्यावरती घ्या. आता I am checking the supra axillary, middle axillary, and infra axillary. Say again. 1. Okay. Here also. 1. I am getting the enough or equal type of the sound vibrations on both the sides. That means tactile vocal fremitus is equal and normal, not too much hard and not too much low. Okay. Now when I am doing this back examination, the position is also important, how one person should sit. Okay. Okay, you can take this position from this side. Type vocal fremitus by asking the patient to say 111. 1. Suprascapular, middle scapular, infrascapular, and interscapular. So this should be examined, all area for the sound waves. So this tactile vocal fremitus increases in consolidation and reduces in the plurals. Okay, next. Now I am going to do the percussion. So percussion is done in the intercostal spaces from both sides, right, left, then axillary, and also from the back side. So I am doing the percussion. So this sound is called, actually you can hear, but when I go to the cardiac area, you will see the difference. Here. Little bit dull over here. So this area is called as a cardiac dullness. So I am examining right side, left side. Haat डोक्यावरती घ्या. Then when I am using the axillary region like this, supraaxillary, middle axillary, and infraaxillary. Right side as well as the left side. Okay. पाठीमागच्या बाजूला वळा. Percussion from the back side आहे. परत मगाची पोझिशन घ्या. खाली वाका. Thank you. Suprascapular, middle scapular, infrascapular. This examination method is called as a percussion. Everywhere there is a resonant note and only cardiac dullness is there. So here also interscapular. Okay, परत सरळ बसा. Next. Now the last examination is auscultation. So that we are going to do with the stethoscope. First I am going to check only the air entry. First air entry. श्वास घ्या सोडा. Supramammary, middle and inframammary. श्वास घ्या सोडा. घ्या. घ्या. श्वास घ्या. So at the same time, the person can do both the things. One thing is the intensity. It's equal. Intensity of both the sides is equal. And secondly, I can check the quality, whether their sounds are vesicular or the bronchial. All over here, I will get the vesicular. But only over in this region, I will get the bronchial sound, that air is flowing through the pipe. So, but if I get a bronchial sound over here, that indicates some cavity due to the tuberculosis or some pneumonic patch. So only this part is bronchial, all other is like a vesicular, which is called as a rustling of leaves. So this front side I have checked. Now I am going to check the axillary part. परत हात डोक्यावरती घ्या, तिकडे तोंड करा, श्वास घ्या, सोडा, घ्या, 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 घ्या. Especially remember in the pleurisy, dry pleurisy, first stage you get a rub over here. If you heard pleural rub on only one side and patient is complaining, I am getting a severe pain when I am breathing, then definitely it is a sign of pleurisy and you must check the X-ray which show the costophrenic angle is obliterated. आता मागच्या बाजूला वळा, मगासारखी position घ्या. This is particular position where the scapulae get expanded. Again suprascapular, श्वास घ्या सोडा. This area is very important. श्वास घ्या सोडा. घ्या, 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 घ्या. Okay, समोर या. Now I have to check the adventitious sound. That means whether there is a bronchi or the crepitations. Of course, that I cannot show you with this, but procedure is the same. You have to घ्या श्वास सोडा. घ्या, 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 घ्या. So when you put the stethoscope, theoretically it should be done in 3 steps for examination purpose. But in our practice, 3 things we do together. One, we check the intensity. Second, what we check, whether sound is vesicular or the bronchial, whether there is an adventitious or the pathological sound, like rals are there, bronchi are there, crepitations is there, wheezing is there. In the asthmatic patient, there will be wheezing. The last is important, is like TVF. In the palpation, here we get the vocal resonance. The same method is there. Principle is also the same. Sound waves travel more fast in solid medium. इकडे बघा, परत 999 म्हणा. 9 9 9 9 9 9 9 9 9 म्हणत राहा. 9 9 हात डोक्यावरती घ्या. तिकडे बघा. म्हणा. 9 म्हणत राहा. 9 9 9 9 9 9 9 बस. पाठीमागे वळा. So I am checking the vocal resonance. Position घ्या मगाची. खाली वाका. Scapula is apart. म्हणा. I am getting the equal resonance. This is called as a vocal resonance. This is increased in the pneumonia and decreased in the pleurisy. Okay, पुढे बघा. Next. So my dear friends, this nearly completes our examination of the respiratory system. But in addition to our clinical examination, one must do some investigations like X-ray test, AFB, bronchoscopy, and even the spirometry. And then only we can confirm that this patient is having tuberculosis, this patient is having bronchiectasis, this patient is having all other things, bronchitis, emphysema, whatnot. So this will end the examination of the respiratory system. So once I repeat, examination is done in 2 ways. One is upper respiratory system and one is the chest as such. Upper respiratory means nose, oral cavity, pharynx and larynx. And in the chest, inspection, palpation, percussion and auscultation. The most important thing is TVF, tactile vocal fremitus, and the vocal resonance in the auscultation. So I thank you very much for Mr. Kai and thank you for all you people, students, to make this successful, this particular project. Thank you.